Hello everyone. Now we will continue with the next section on distribution. The section is on factors that are affecting the protein drug binding. So in the last section we studied what is protein binding and what are the various proteins that helps in binding of the drug, and what will happen if the drug will bind to proteins. And now this section will discuss on what are the various factors that contributing to protein drug binding. So the factors that contributes to the protein drug binding classified into four. First one is the factors that related to the drug. Second is factor that related to protein. Third one is drug interaction, and fourth one is the patient related factors. We'll go through one by one. The first one is factors related to the drug, protein, drug interaction, and patient related factors. Now, what are the drug related factors? So this one easily you can remember it. The first one is drug related factors. You can just go through the various factors. Factors related to drug: first is physicochemical factor of drug, second is concentration of drug in the body, third is affinity of the drug in the body. Physicochemical properties of the drug, concentration of drug, affinity of drug. Factors related to the protein includes physicochemical property of the protein, concentration of the protein, and number of binding sites. Third, drug interaction include competition between the drug for the binding site, competition between the drug and the normal body constituents, and allosteric changes in the protein molecule. These are the drug interactions. And finally, the patient related factors includes age of the patient, intersubject variation, and disease states. So these are the 12 main factors that can affect the binding of drugs with the protein. Okay, now in this section we'll go through one by one, and you must able to understand what will happen in distribution. Now we are learning about distribution. We are learning about the factors affecting distribution. Among protein binding is one factor that can affect distribution. If protein binding is high, the distribution will be less. If protein binding is high, the distribution will be less. You keep this concept in your mind and you go ahead. Then and there only you can understand what are the another 12 points we are going to discuss. The last session we discussed a protein bound drug is pharmacokinetically and dynamically inert because of its higher molecular size. This is the concept behind this one. Okay, now first one is physicochemical characteristics of the drug molecule. So same as that of other absorption distribution, also we learn physicochemical properties. Here also the main physicochemical property that can affect is lipophilicity. Higher the lipophilicity, higher the binding of drugs with the proteins. Higher the lipophilicity, higher will be the binding. An example of this is the cloxacillin as well as ampicillin. Okay, cloxacillin as well as ampicillin given as intramuscular injection. So it's attributed to higher lipophilicity and it binds 95%. Cloxacillin is highly lipophilic and it binds 95% to proteins, whereas the ampicillin less lipophilic and it bound only 20%. So both cloxacillin as well as ampicillin administered as intramuscular injection. Cloxacillin is highly lipophilic, ampicillin is less lipophilic. Highly lipophilic is the only reason that cloxacillin bound 95% with the protein, whereas ampicillin bound only 20%. What is the significance of this? So highly lipophilic, example is another example. Highly lipophilic thiopental tends to localize in the adipose tissue. This we have seen in the first session, organ size and perfusion rate. Organ size and perfusion rate. We have learned thiopental bound. There we learn because of what? Because of organ size and perfusion rate. Because of organ size, the thiopental was highly localizing on the adipose tissue. Here, the high lipophilicity of the thiopental is also another reason for binding with the adipose tissue. This is a part of what? Lipoproteins. Then, anionic acidic drugs like penicillin, sulfonamides bind more with the human serum albumins, and cationic drugs mainly bind with the alpha-1 acid glycoprotein. So, here in the physiochemical characteristics of the drug, you keep in mind the point lipophilicity, example as cloxacillin as well as ampicillin. The second factor related to the drug is concentration of drug in the body. Simple thing. So how concentration of a drug can affect? You know very well. Now don't read it. Please listen. Now you know very well the amount of protein in the body varies from protein to protein. Lipoprotein is high in amount. We have seen hemoglobin high in amount. Then albumin is little bit less than that of lipoprotein, and lipoprotein amount may vary based upon our physiological condition. And coming to globulin, alpha-1 acid glycoprotein, AAG, so this amount of these proteins are comparatively very less in our body. Okay, now a drug that bind with albumin, what happened? Albumin amount is high. The concentration of the drug in the body is less. We are administering one dose, right? Now what happens is, if the amount of drug what we administered is less compared with that of the amount of protein, the proteins are not saturated. But if the amount of drug is higher than the amount of protein, the proteins are saturated. So one way the concentration of the drug in the body can affect what? Protein binding. Now read it. The extent of drug protein binding can change both the change in drug as well as protein concentration. The concentration of drug that binds to human serum albumin does not have much influence, as the therapeutic concentration of drug is sufficient to saturate it. The therapeutic concentration of lidocaine can saturate alpha-1 acid glycoprotein, with which it binding as the concentration of AAG is much less in comparison to that of human serum albumin in the blood. Now you listen to the significance. So a drug that binds to the albumin, if the drug concentration usually will be less than that of albumin concentration, because the reason is albumin concentration is high. The drug will not saturate the albumin, whereas concentration of AAG is less. Alpha-1 glycoprotein concentration is less in the blood. The drug example is lidocaine. The drug which is administering at a higher concentration can saturate the AAG, because some drug molecules are having higher affinity with specific proteins. So the drug molecule what we are administering having higher affinity with alpha-1 acid glycoprotein will bond with AAG, and if the amount of drug is higher than that of AAG will be saturated. Now what happens? The amount of unbound drug in the body will be higher. This will be distributed. It may produce the pharmacological action. That's it. The third one is affinity of drug for the particular component. That is, we know drugs are binding with the protein based on its affinity. The one which having higher affinity will bind very faster, and the dissociation of protein drug complex is based upon the affinity. If the protein drug complex is if the drug is having high affinity with a particular protein, it takes long time for the dissociation. Example is this one. Lidocaine has a greater affinity for alpha-1 acid glycoprotein than that of human serum albumin. Digoxin has a greater affinity for protein of cardiac muscle than skeletal muscles of plasma. Okay, now another example is iophenoxic acid. Its iophenoxic acid is having higher affinity with that of the proteins. So what happens, because of its higher affinity with the proteins, the half-life of iophenoxic acid remains 2.5 years. That means if you administer this iophenoxic acid, it bound with the proteins, and because of its affinity, it remains longer time with the protein. It never dissociates, but it is not forming any covalent bond. Only because of its affinity, it maintained as a protein bound form without dissociation, and it is remaining for a longer period of time. It has a half-life of 2.5 years. So this is the significance of affinity. So higher the affinity, what will happen? Takes long time for dissociation, and it remains for a longer period of time. So the half-life will be higher. Okay, now the 3 points we are revising: physiochemical characteristics of the drug. Okay, main point is lipophilicity. Higher lipophilicity, higher the binding. If higher the binding, lower the distribution. Second point is concentration of the drug. If the concentration of the drug is less than the concentration of protein, it is not saturated, it is remaining in the bound form. Whereas if the concentration of the drug is higher than the concentration of the specific protein, the drug may saturate the protein, and it may available as what? Available in the unbound form. A portion of the drug will be available in the unbound form. Third one is lipophilicity. Third one is affinity. Higher the affinity, higher the half-life. So these are the drug related factors that can affect your protein binding. Next one is protein related factors. Exactly same as that of drug related factors, the protein physiochemical properties of the protein. So mainly lipoprotein or adipose tissue tend to bind with the lipophilic drug by dissolving in the lipid core. The first point, lipophilicity, is the main thing. So same as that of the drug molecule, protein, lipophilicity of the protein is also a major factor for protein drug binding. And the one more thing is physiological pH determine the presence of anionic or cationic group on the albumin molecule to bind with the variety of the drug. That is, the physiological pH of the blood may also affect binding of drugs with the protein. So these are the two factors that can affect the physiochemical factors of the protein that can affect the binding with the drug molecules. The second factor is concentration of a protein binding component. So most of all drugs binds to albumin because it is present higher concentration than other protein. That's it. Simple thing. Apart from that, so higher the concentration of protein, higher will be the binding. Alpha 1 acid glycoprotein is less in number. So lidocaine has affinity only to AAG. Lidocaine is not having that much affinity with albumin. Lidocaine do not have much affinity with the glycoprotein. Lidocaine has only affinity with AAG. So AAG amount is less. AAG amount is less means it can bound only less amount of drug. If it less amount of drug is only bound means more amount of drug is in the unbound form. That's it. Okay, the last protein factor related to the protein is number of binding sites. This is another important point. So only for albumin we have 4 binding sites. Rest all the proteins are having only 1 binding site. So the protein that has the highest binding site will get more amount of drug. A particular drug molecule that is having affinity towards the albumin means a more amount of drug will be protein bound. The particular drug will be highly protein bound. But a drug that is having higher affinity with the glycoprotein, since glycoprotein is having only 1 binding site, only less amount of drug will be bound to the proteins. So what happened? Less amount of drug is bound means more will be the distribution. If more amount of drug is bound with the protein, lesser will be the distribution. Okay. Now one more critical point is alpha 1 acid glycoprotein concentration is commonly less in the blood, but in certain situations, like in the presence of human serum albumin and AAS, that is alpha 1 acid glycoprotein, in the presence of human serum albumin. So it has reported that AAG has two binding sites. That means AAG has only one binding site for lidocaine. This is especially in the case of lidocaine. Generally, AAG has a one binding site, but in the presence of human serum albumin, it is observed that lidocaine has bind more with alpha 1 acid glycoprotein. That means the number of binding sites has observed to be increased to 2. From 1 it has increased to 2 binding sites for what? Alpha 1 acid glycoprotein. So these are the factors related to protein that can affect your distribution. Okay, the third one is drug interaction. Okay, now you please listen before going for reading the slide. Please listen, let me tell you what is the drug interaction, then we'll go back to the slides. Okay, drug interaction you might have studied in the previous years. That is interaction of a drug between other drugs, right? Now what is interaction here? Now we are learning about binding of drugs with the proteins. Binding of the drug with the protein is based upon the affinity of the drug. Now what happens when two drug molecules administered together? If the two drug molecules are having good affinity with a single protein, both the drug molecules may compete for the single binding site. Drug A and drug B. A is having affinity towards albumin, B also has affinity towards albumin. So both A and B competes each other to bind with the albumin. Both are having same affinity. If one is having less affinity, the other one also will be binding. So if the drug is having same affinity, they compete with each other. So this competition of drugs to bind with the protein, here we call it as drug interaction. Competition of drug molecules with high affinity with a single protein, when they administer together, they compete each other to bind with a particular protein, and this interaction we call it as the drug interaction. In other way, it is also known as the displacement reaction. So if at least any one drug molecule is having higher affinity, what will happen? The drug with the higher affinity may displaces the other. So the one which is displaced out, we call it as the displaced drug, and one which displaces the drug, we call it as a displacer drug. This will explain with the help of an example. A patient on warfarin therapy. Okay, now we listen carefully, please. A patient on warfarin therapy. Warfarin is highly bound with human serum albumin. Warfarin has high affinity with the human serum albumin. So this patient, if you administer phenylbutazone is also having good affinity or a better affinity with human serum albumin. Now what happens? Warfarin has a higher affinity, warfarin has a good affinity, and it is highly bound with albumin. And if you administer phenylbutazone to the patient on warfarin therapy, the phenylbutazone acts as the displacer drug, and it displaces the warfarin from the albumin binding site, and it displaces the phenylbutazone binds with the human serum albumin. I'll explain once again. A patient on warfarin therapy, if administered phenylbutazone acts as the displacer drug because of the higher affinity of phenylbutazone with the albumin. Phenylbutazone displaces the warfarin from the protein, and phenylbutazone bound with the protein. Now who is bound with the protein now? Warfarin is in the unbound form, phenylbutazone in the bound form. The phenylbutazone is the displaced drug and the warfarin is the warfarin is the displaced drug and phenylbutazone is the displacer drug. Warfarin is the displaced drug and phenylbutazone is the displacer drug. So this we call it as the drug interaction. Now in certain cases, now you can when you get the time you can just go through the slides. Okay, that's it. I'm not reading the slide. Now in certain cases the drug interaction is clinically significant. This portion is a little bit important, so please listen. Some cases the drug interaction is clinically significant. When a drug interaction can be clinically significant? Okay, a clinically significant drug interaction can happen if the first condition, that is a displaced drug. Now the displaced drug here it is warfarin. If the displaced drug is more than 95% bound, I'll explain one by one, you please listen. So the displaced drug is 95% bound. Means what? The warfarin is displaced. If the displaced drug is 95% bound, means warfarin is administered to a patient. Warfarin is having a protein binding of 95%. That means 95% of warfarin is bound with the protein, remaining 5% is only unbound form. This 5% only produces the therapeutic activity. 5% is only producing the therapeutic activity. If you administer 100 mg of warfarin, 95 mg will bound with the proteins and 5 mg will the unbound form, and this 5 mg produces the therapeutic activity. Now you think in this way. Usually what happens, so this 5 mg is only producing the action, 5 mg is only metabolizing, 5 mg only distributes, 5 mg only eliminates. If the 5 mg has eliminated, once the amount of unbound drug is decreasing by means of elimination, the bound form of drug will come back to unbound form. The bound drug, a portion of the drug bound with the protein may convert to unbound form. So there exists a what you call an equilibrium between the bound as well as unbound drug. As the amount of unbound drug reduces, the bound form converts to unbound form. Okay, so this happens simultaneously. So always, what is the amount of drug present in the body? In that 95% will be bound form, 5% in the unbound form, and this 5% only produces the therapeutic activity. Now when phenylbutazone displaces the warfarin and phenylbutazone bound with the protein, what happened? More amount of warfarin is displaced out. Initially the bound warfarin was 95%, but currently the bound warfarin is displaced by phenylbutazone and the amount of unbound warfarin has increased. Amount of unbound warfarin has increased. Now what happened? Only 5% of warfarin is sufficient to produce a therapeutic activity. If more amount of bound warfarin is converted to unbound form, what happens? More amount of warfarin is ready for producing the therapeutic activity. This results in increased activity, or it can lead to toxicity and adverse drug reactions. This is the clinically significant drug interaction. I hope the point is clear. If you are not clear, just reverse it, just play it back, you will be getting it. I will explain the opposite case also. A protein, another example, a drug is only 25% bound with the protein. Okay, Remaining 75% is in the unbound form. That means a 75% is in the unbound form, 75% is producing the therapeutic activity, and 25% is only in the bound form. Now if this 25% is also, if it is converted to unbound form, comparing the percentage, it is less, that it may not produce any therapeutic activity. I will explain in another way with the same warfarin itself. 95% is warfarin bound with the protein, 5% is only unbound. So because of, you think in this way, because of phenylbutazone drug interaction, the concentration of bound form is changed to, decreased to 90, and concentration of unbound increased to 10. 90-10. Initially it was 95-5 ratio. After drug interaction, it has changed to 90-10. Now what happened? How much percentage has increased? Initially it was 5%, it has reached to, now it is unbound concentration is 10. 5% has increased. That means total 100% increase. Initially required quantity is only 5%. Required quantity is only 5%. Another 5 more percentage has increased. That means the increase is totally 100%. 100% increase can result in toxicity. So this happens only if the displaced drug is highly bound with the protein. Okay, so here is the first one, displaced drug. Example is warfarin is more than 95% bound. Second, if it has small volume of distribution, a clinically significant drug interaction can happen because of displaced drug warfarin. First condition was is more than 95% bound. Second condition is small volume of distribution. Now listen, if the volume of distribution is high, what will happen? If the drug is displaced also, if it is having higher apparent volume of distribution, it will be distributing throughout the body. Means it will distribute to the adipose tissue, it will distribute to the bones, it will distribute to the skin, it will distribute throughout the internal organs. Whatever the unbound form, it everywhere it has distributed. It is not localized in any part of the body. Whereas if it is having less volume of distribution, what will happen? It will localize within the systemic circulation, or it may localize within the organ which is having higher affinity. This may produce a toxicity. Point is clear, right? Third point, shows a rapid onset of therapeutic or adverse effect. Some drug, what is the onset of action? The time taken for the drug to produce the action, we call it as onset of action. The time taken for a drug to produce the action is known as the onset of action. Suppose a drug after reaching into systemic circulation, the onset of action 5 means after administration within 5 minutes it produces the therapeutic activity. Some drugs, the onset of action will be 30 minutes. That means after administration it takes 30 minutes for the drug molecule to produce the therapeutic activity. Some drugs are highly active, some drugs produce a delayed action. Some drugs may be active after a period of administration. Now, if the displaced drug is having a narrow, or a rapid onset of action, means the moment it reaches the blood, the moment it produces the action. So as the moment the concentration of unbound drug is increasing, immediately it produces higher therapeutic activity. But instead of that, if the drug is having a faster, if the drug is having a high onset of action means it is producing a action after a long period of time of 30 minutes. High onset of action means what? If the drug is converted to unbound form also, some time is there for this drug molecule to produce the action. By the time the drug molecule can distribute, by the time the drug molecule can eliminate from the body also, both the things can happen. So if the drug is showing rapid onset of action, this reaction will be clinically highly significant. And the last one is having high narrow therapeutic index. A therapeutic index means the range between the minimum effective concentration and maximum safe concentration, therapeutic range. You know what is the in biotechnology you learned what is the minimum inhibitory concentration and maximum safe concentration, something, right? So the same way, the minimum effective concentration, that is the concentration, minimum concentration required to produces action, and the maximum to what concentration the drug is safe, that is known as the maximum safe concentration. The range between the minimum effective concentration and maximum safe concentration is known as the therapeutic range or therapeutic index. Now listen. For a drug molecule having minimum effective concentration 50 and the maximum safe concentration is 100, that means the drug concentration in the body must be between 50 to 100. If it is less than 50, it will not produce action. If it is more than 100, it may be toxic. So 50 to 100, 50 to 100 is a good range. We have a difference of 50. Above 50 and 100 in the if the drug concentration remain means that's well and fine. This is a broader therapeutic index. Rather, instead of that, you think in the way the minimum effective concentration is 80, maximum safe concentration is 100. That means the drug concentration in the body always must remain within 80 to 100 to produce the therapeutic action. Got the point? In between 80 to 100 only it will produce the action. If the concentration is between 80 to 100 only for 1 hour, only for that 1 hour it may produce the action. The remaining time it will be less than 80, it may not be producing any action. Now we come back to the point. Now we got what is large wide therapeutic index and narrow therapeutic index. Narrow therapeutic index means 80 to 100. Broad therapeutic index means 50 to 100. That means the range between minimum and the maximum will be higher in case of broad. Now, the displaced drug is having narrow therapeutic index. It should be 80 and 100, or it can be 100 and 120, 150 and 170, 150 and 160. These are examples of narrow therapeutic index. If the displaced drug is having narrow therapeutic index, if the displaced drug is displacing more, converting from bound to unbound form, what will happen? Immediately the amount of unbound form is increasing. Immediately it can go beyond the maximum safe concentration. If it goes beyond the maximum safe concentration, it will produces the toxic reaction. So these are the 4 conditions for a displaced drug can produce clinically significant drug interaction. So hope it is clear for everybody. If any doubt, you can message or ask me at any point of time. Now next is when a clinically significant reaction can happen if a displaced drug, because of displaced drug, how a clinically significant reaction can happen. This is simple. Now, has high degree of affinity as a drug to be displaced. Now we have seen phenylbutazone and warfarin. Phenylbutazone is having a higher affinity than warfarin to bind with the albumin. Then and there only this drug interaction can happen. If phenylbutazone is having less affinity, it may not happen. It competes for the same binding site. That means both phenylbutazone and albumin, here it is competing for human serum albumin. Whereas if the one drug is competing for another protein, means this reaction may not happen. The drug protein concentration ratio is high. That is, drug protein concentration ratio is high. Ratio, if that is drug divided by protein ratio, if it is high, it becomes a clinically significant reaction and show rapid and large increase in plasma drug concentration. Show rapid and large increase in plasma drug concentration. Means what? The drug, after administering, it easily absorbs. It absorbs very fastly. If it absorbs fastly, it appears fastly in the blood. If it appears fastly in the blood, it easily binds with the proteins. So the task is simple. So shows rapid and large increase in plasma drug concentration. There are more chances for displacement reaction. If the drug is having affinity, if it appears slowly, means slowly only it will interact, slowly only the warfarin may come out, and slowly it will warfarin may eliminate also. But if the phenylbutazone is appearing very fastly, it will interact very fastly with the protein, it will increase the amount of warfarin also very fastly. So these are the 4 conditions of phenylbutazone or a displacer drug can produce a clinically significant interaction. Okay, so this was drug interaction between the drug and the drug interaction. Next one is the competition between drug and normal body constituents. That means this example especially mean fatty acids on top. The body constituent can also interact with the drug, result in significant drug interactions. Example is this one. The free fatty acids interacts with the drug molecule that bind primarily to human serum albumin. When free fatty acid level increases in several conditions, this is the condition especially fasting, diabetes, in myocardial infarction, etc. The amount of human serum, so amount of fatty acids can be increased. Now what happened? So fatty acid which bind to the albumin influences the binding of several drugs like benzodiazepines, okay, and propranolol. So the fatty acid has the affinity to albumin. If the fatty acid is having higher affinity with the albumin, it binds with this fatty acid is not an external drug. Fatty acid what is present in our body. Fatty acid has an affinity with the albumin. Thus what happened? Fatty acid bind with the albumin, and if it binds with the albumin, the drug molecule if we administer, like example is benzodiazepine is also having affinity with the human serum albumin. Benzodiazepine cannot bind with the albumin because what? Fatty acid is bind with the albumin. Fatty acid is there in our body. Fatty acid concentration can vary because of the food what we are consuming, disease condition, fasting condition. The amount of fatty acid can be higher than the amount of drug what we are going to administer. The amount of fatty acid is higher than that of albumin, it will saturate albumin. So whatever drug like benzodiazepine, if you administer, it will not bind with the protein. If it is not bind with the protein, what happen? The benzodiazepine will exist in the unbound form. If benzodiazepine exists in the unbound form, what happen? It will increases the therapeutic and toxic reaction. That is the significance. Another example is, whereas in case of warfarin, this fatty acids which can increases the binding. The presence of fatty acids can increases the binding of warfarin. Another example is bilirubin. Okay, bilirubin binding to human serum albumin. Bilirubin, normal body constituent, bind with human serum albumin. So this can retard binding of various drugs like sodium salicylate, sodium benzoate, etc. Okay, so bilirubin bind with the human serum albumin, which retards the binding of drugs like sodium salicylate, sodium benzoate to bind with the human serum albumin. So what happens? The sodium salicylate and sodium benzoate, these are having higher affinity. So this drug molecules, again there it undergoes a drug interaction with the human serum albumin. So if there happens a drug interaction, what will happen? Bilirubin will be displaced out. If bilirubin is displaced out, what happens? The free bilirubin concentration is increasing. If bilirubin concentration is increased, it may conjugate with the liver and may cause toxic effect in one way. The second way, this especially in case of neonates. The blood-brain barrier is poorly developed. So the bilirubin what is displaced out can easily permeate the blood-brain barrier and can result in a condition called kernicterus characterized by degeneration of brain and mental retardation. I will explain it once again. Bilirubin generally binds with human serum albumin. If you administer any of the drugs like sodium salicylate, the sodium salicylate also has affinity with the albumin. Sodium salicylate can displaces the bilirubin and bind with the albumin. This displacement interaction can result in increasing the concentration of bilirubin. Increase in the bilirubin concentration can bind with the liver, one condition. Second condition, it can penetrate the blood-brain barrier of neonates, because neonates, the barrier systems are poorly developed, and because of this, it can easily crosses the blood-brain barrier and it can make a condition called as kernicterus, that is the degeneration of brain and result in mental retardation. So this is the significance of drug interaction between the drug and the body constituents. And the last point is certain allosteric changes in the protein molecule. So by means of any reason, if the structure of the protein has changed, if the structure, suppose proalbumin, it is having 4 different binding sites, because of any reason, any drug interaction, the structure of albumin has changed, means a particular drug that has higher affinity with the specific site will not bound with the albumin. So what happened? The amount of particular unbound drug will be increasing in the body. This can produce toxic reaction. So overall, this is the conclusion. What is that? A protein binding can decreases the distribution, less protein binding can increases the distribution, because due to the drug interaction, if any of the concentration of unbound drug has increased, means that can result in toxicity or adverse drug reactions. Okay, so this topic is not completed yet. It takes a little more time, so I'm just stopping this now here, and I'll make it as another session with some of other patient related factors and significance of protein binding. I'll make it as another one more session next day. Okay, so thank you. I just go through, listen it properly. Actually this topic is little bit important and it takes little more time for you to understand it also. So listen with the patience, go through, and if any doubts means you just ask me. So far you have not asked any of the doubts. I hope it is clear for you. Okay, then thank you.